Hi, everyone, and welcome to the HCBiz show. This is the weekly show where we dig into the issues affecting the business of healthcare. We like to take a very practical approach to the matters and try not to spend too much time speculating and hyping, although there will, based on the topic, have to be a little bit of speculation today. But we're going to be diving in and talking about Trumpcare. Obviously, a big topic right now, somewhat unexpected result for many. Basically we're having real conversations about major changes or even repeal to Obamacare, what that might mean for healthcare. And as always, we want to take a look at this and talk about, from a business standpoint, from an innovation standpoint, what do we all need to be thinking about right now, and how can we be careful not to get caught up in the spin and the hype in a way that distracts us from what we really need to be doing today to successfully run our business, take care of patients, and do all the things that we have to do on a day-to-day basis. So joining me, as always, is my co-host Shahid Shah, coming to us from the HIT Lab in New York City, I believe.
That's right.
Very good.
Manhattan.
Glad you can make it. Awesome. And joining us from Brookings Institute is Niam Yaraghi, who is a fellow there and is doing some research in the area around Trumpcare and the future of health IT. Welcome, sir.
Thank you.
Good to have you both. So, Shahid, why don't we start off, as you said, you're at HIT Lab in Manhattan. What's going on there? What are you doing? What are you seeing?
So yeah, this week, two pretty big events going on. One is called MedStarter, which is focused on a lot of startups who want to get into healthcare IT. That was yesterday and Monday, and yesterday, today, tomorrow is HIT Lab, which is also focused on startups in a slightly different angle. HIT Lab actually has a pilot program where they research and allow startups to submit to their institution and say, hey, I've got a great idea. I need to have pilots, and could you help me find some pilots? And so they have the pilot program. They have a connector program, which connects institutions with startups. Today, I really heard a great talk by Karen Nani here at the HIT Lab Summit. She used to be the CEO at AHIP. She is now the CEO at Emblem Health, which is a nonprofit health plan in the New York area. And she just did a great job talking about what are the realities of where the payers' needs are from a digital perspective, as well as a transformation perspective. And she did something pretty unique, which was standing up on stage, just telling all the startups, what do they really need? Like, come to us with, and gave a nice little list of things that startups should think about when they're considering how to sell their materials, whether it's in provider land or payer land. And she really did a good job of laying out, what the health plans need today, what do providers need, what do caregivers need, and how could you, as a startup or an innovator, come and work with a health plan, which was great, I think, for a lot of the participants here. So HIT Lab is really nice. They've been around for a little while, and it's focused on the New York area, but more broad as well in certain aspects. But I just love it. Just the juices flowing, gets the ideas rolling, and it's a terrific event in general.
Yeah, that's awesome too, to be able to connect the startups with those the established players and potential customers, because, having been through that a number of times, the getting people's attention early on when you're a startup and you don't have experience, you don't have, proven and documented ROI, really, really tricky to get the right folks to spend time with you and talk with you. So that's huge. It looks like we're having a little bit of signal trouble here with Shahid. So we'll jump over to you, Niam, and kind of get into the main topic of the show here. As we touched on in the opening, there's a lot of uncertainty right now, and I think largely fed out of the unexpected position we find ourselves in right now, and with the new administration, Republican-held Congress and Senate. And things that didn't seem possible even just a few weeks ago before the election are now very real conversations. And as I look at this, it doesn't surprise me that people are reacting, are speculating, are worrying, whatever you want to call it. But as I read through all of the commentary out there on the web, what jumps to mind for me is change is nothing new in healthcare, and certainly not even huge change is not something new in healthcare. And you can look back over the course of the 25 years, and you can see, the last 25 years, you can see us moving into HMOs, then out of HMOs, then starting to talk about value-based care and the push that we're in right now. That stuff's largely going to continue. So, from your perspective, what's your read on what's going on right now, and why are people surprised that we are faced with yet again more major change in healthcare?
Yeah, I agree with you that change in overall healthcare policy in the United States is nothing new. However, all the major changes were expected. We were expecting Obama to win, and we knew exactly what he is going to do. We knew about, the fundamentals of Obamacare before he was elected into the office. So although Obamacare was a major change, people were expecting that. The problem that we are having now, it's not a problem, but the situation that we are facing now is that it is a change that we were not expecting. And therefore, that is why everybody is so anxious to see what is going to happen. So I think that is what differentiates the situation that we are having today with the situation that we had 8 years ago. However, I think when it comes to changes, especially the ones that we didn't expect, it's better to be optimistic rather than pessimistic at an individual level. Especially, I'm very glad that we do not see those things that we were warned about. So when it comes to healthcare, the two most important positions, the Secretary of HHS and the Administrator of CMS, which I think the second one is even more important and more influential than the first one, are two solid people. So they have relevant background. Interestingly, Congressman Price is a surgeon himself. So it's very refreshing to see that a physician is being appointed to lead an organization who is basically going to change the life of so many physicians in the next 8 years. So he has an understanding, and it becomes very important when we see the changes that has been implemented over the last 4 years specifically are the ones that seem to be ignoring how medicine works. The reporting requirements that were put in place, according to the estimates published in Health Affairs Journal, costs physicians 2 days per week to just comply with all those different requirements that they are, which not only we haven't seen any benefits from all of those reporting requirements, the signal that it sends me is that those people who wrote those rules and made those policies didn't know how a typical physician spends his hours in a typical workday. So him being a physician is a very good sign, especially since I think the last physician that was heading HHS was during the 90s era, so 1990s. So I think based on the very limited information that we have right now about these two individuals, both of them seem to be very reasonable choices.
Gotcha. So Shahid, welcome back. Glad you got resituated. So on that front, we were just kind of talking about the uncertainty and people, how people are reacting to it, and largely that we believe it's because it was an unexpected change of course to a large degree, and there's a lot of uncertainty behind it. So it's unexpected, it's uncertain. It makes sense that people are kind of like, So, what's your take on it? You're all over the country, you're talking with people. What are you hearing from folks? What are they worried about? What are they hoping for? What's your take on this at this early stage in the changes coming?
Yeah. So yesterday, while I was at MedStarter, I did a talk on speculation in healthcare. So if at this point we can make sure that, especially as innovators and people who are looking about where things are headed, let's not speculate. There's not going to be a disruption in healthcare any more today than it was 8 years ago during the President Obama transition. Why? Because this is a multi-trillion-dollar industry. It takes time to change billion-dollar industries. So first, we all need to, check our temperatures, calm down. Nothing is going to change in the next 6 months. I mean, there's still a lot to actually do. But I do agree with Niam on the fact that the two people that have been chosen for these two particular very important tasks the positions are operators. They're not, they're tacticians. They're not big strategy people, but they're tactical people that understand how things are supposed to work. Now, we may not agree with every one of the directions that they want to take us in, but at least we're going to know that those directions are going to come from a sense of having been in that world, not in the governance world and not just in the insurance or other worlds, but in the care provider world. So we're going to see a little bit of benefit there. Now, when I did my talk at MedStarter yesterday, I think it's on video, I did a 15-minute overview on how the Congress works, how the rulemaking works within HHS, what does CMS do with rules, and how you can understand really what's going on, looking on thomas.gov for what's going on there, looking on the federal registers, understanding where rules are actually being made. So there's a reason for us to be both calm and optimistic. There's really no need to be pessimistic because there's nothing we can do, right? At this point, exactly. there's a new administration coming in, and as innovators, we are always given challenges. So at worst, we should consider that this change is a challenge. And at best, it's a huge opportunity. In either case, as innovators, we have to react to it. And so what we should be looking at is what we're definitely going to see is a level of decentralization that says not everything is known in Washington. And so, I remember one of the things that President Obama said when he first came into office was that he wanted to make government cool again. Well, that ain't the position of the new administration, right? I mean, they think government is generally in the way. Now, given that change in culture, what are we likely to expect? Those expectations are really around the idea of decentralization, more movement of going into the state-based areas. We're going to see that the idea of control with respect to what's going on in healthcare should be more at the provider level than it should be at the insurer level. So these kind of changes are coming, but they're not necessarily good or bad. They're just changes because it's not like the new administration knows something that the old administration didn't. They're going to try things in a different way. So I think that's really our challenge and our opportunity right now is how do we stay calm, understand what the changes are going to be, and the culture of that change, because that's really what's going to drive these impacts and things that we're working on. It's not going to be any one change, but it's a group of changes that drive where we're headed. But we also have to understand, as the culture comes in, it takes about 1.5 to 2 years for this culture to set in. In that meantime, nothing really could change, right? Because even if you change the law in February or March, which is near impossible, it would take you 6 to 9 months to work through things and regulations. Then all of the stuff that the staff has to do to learn all of these things at CMS and other places. There's a lot to happen. So not that much to worry about.
Yeah, sure. I mean, even if you just look at the timelines of MACRA, the biggest recent change is, the legislation hit, and then it was months before the proposed rule came out, and then it was months after that before there was a final rule, and they're still technically, I believe, in a form of a comment period even on that. So the time across that, you're at least 18 months to 2 years for some major piece like that to even get started, let alone for it to start to have an impact on the way that people are actually working and doing things. So yeah, I'm with you 100% on that front.
So like imagine in many of the cases where President Obama wanted to do certain things, he got the laws passed and they still went to the Supreme Court, right? So there was a lot of action in court after that. A lot of the regulations and the executive orders that he wanted to pass, again, lawsuits, et cetera, will keep those paused and won't be able to be implemented as fast. So it doesn't matter which direction you're in. I mean, this is one nice thing about our country is our Constitution prevents, real disruptions. And it's designed to do that in a more controlled fashion as much as possible. And regardless of what side of the election you were on, change was inevitable. For us as innovators, though, the good news is most of this is probably likely to give us positive change, at least for the next couple of years, because it gets our conversations going about value-driven care, decentralization. What do all these quality metrics mean? What does a quality payment program actually mean? And instead of looking at it as a central government authority question, we had that view over the last 8 years. Now we can see what does the alternate view look like, and because we've tried both, which one might work better? We can use real data to help present and illustrate.
Excellent.
I just want to follow up with what Shahid said. I do believe that decentralization is a really important factor, although it may not happen in the near future. But I think it's good news, and it's good reason to be optimistic about the future of innovation, because when we have a centralized healthcare system where policies are solely designed by a group of policymakers here in Washington, D.C., then as an entrepreneur and innovator, your success is correlated with your distance from the center. So you will succeed if you're very close to Washington, either in terms of ideas or in terms of connections. That is why you see, you over the past couple of years, you would succeed in the area of health IT only if you were developing an EMR system that complies with the ONC certifications. If you had another idea of a better EMR that was not complying with all of the certification requirements from EHR, then you had literally no customer to sell your products to. So that is really good news for innovators, especially the ones that are not close to Washington and have ideas that they really want to try. So now it gives them the opportunity to go out and seek real demand for their innovations.
Yeah, right on. And I think it's kind of like this is the thing that everybody has been complaining about from both sides too. This is the doctors have been complaining that they're not allowed to just go do their work the way that they know they need to do their work. The EMR vendors are complaining that they can't, that's difficult for them to innovate and to deliver new things to market because they're constantly chasing regulation. If we do see this type of deregulation and moving away from all of these mandates about exactly how things need to happen, it kind of puts the market in a spot of put up or shut up to an extent too. It's that, okay, now this thing that you've been talking about that preventing you from innovating and making a change is out of the way. What are we going to do with it? And I think from your perspective, Shahid, I mean, I hope that's what you hear people talking about at the HIT Lab and and those types of areas.
Yeah, I think people are so when you look at it from a innovator perspective, because we're innovating slightly on the technology side more than the policy side, I think you're going to see anybody who pays attention to this decentralization aspect, like Niam chimed in really well. I think he laid the case out. One thing that we discussed yesterday, so I did my talk on real innovators don't speculate about how to make sure that we're basing our decisions on actual things that are likely to happen, not fear mongering that's about to be more promoted. After that, we had the panel, and on the panel was Thomas Sang, who was the chief medical officer at the Office of National Coordinator during the Obama administration, the first administration, and David Harlow, who's a very famous healthcare lawyer. And so we were on the panel discussing this very topic of decentralization. And in general, decentralization is good for initial innovation. But one of the fears, and Thomas specifically mentioned this, is it doesn't scale very well, right? If there are 50 states or hundreds of counties, et cetera, that all have their own rules and regulations, sure, you could get something started. The question is, how could you scale it? Now, nobody in the audience bought the idea that no scaling is possible. It just means that while you can innovate faster, you might scale slower, whereas in a central model, you innovate slower, but you can scale faster, right? So again, these are non-evidence driven conversations, so we don't know which one's likely to happen or which one's not, but that's a good thing to keep considering. At the same time, focusing again on this decentralization, The fear on the policy side, and Mandy Bishop, who was also in the audience yesterday, brought up the idea that perhaps, so it might look good from an innovation perspective, but what happens to patients as block grants go out and you have states which cannot afford the kind of care that this other states can? What happens to patients in this environment? Patients are going to get dropped from roles. What happens to them? So from a policy side, there's probably a little bit more to worry about, but it takes much, much longer to establish that policy. From a technology and other side, less worrisome. I think there's a lot of optimism in both cases, but worth considering. I mean, I'd love to hear Niam and Don from you guys. How do you see the decentralization benefiting or being detrimental on policy versus technology in that angle?
I think, Shahid, you put it very nicely. So I think the biggest fear that we have from the policy side is that if Obamacare is repealed, then what is going to happen to all those patients who got insurance under Obamacare, those 20 million people? And I agree with the fact that you said it takes a very long time to see a major change. I was talking with Don before, and I said, in the history of the United States, there is no instance of a welfare program that got repealed. And Obamacare, to a large extent, is a welfare program. So it's politically quite expensive to repeal. I think now it's one of the biggest concerns of Republicans who were running for office over the last 6 years, promising that they are going to repeal Obamacare. And when they got elected in Congress, they were saying that, we're trying our best to repeal Obamacare, but these Democrats do not let us do that. And once they had the chance, President Obama vetoed that. So they say, hey, see, we did whatever we could, but we couldn't succeed because of the Democrats. Now that they have everything, they don't have that excuse. And if they really repeal Obamacare, then how are they going to respond to those 20 million people who got insurance under Obamacare? So repealing, I think, is easy. The most important part is what are you going to replace it with? And although there are various plans out there, no definite choice has been made about which plan to follow or what kind of combination of those plans the administration is going to follow. And as long as we don't have a clear choice for repealing Obamacare, I'm pretty confident that as long as we don't have a clear choice for replacing Obamacare, I'm pretty confident that there will be no repealing of Obamacare. So from the policy standpoint and how it affects the general population, I think, as Shahid said, we don't have to panic. Nothing would change, at least in the foreseeable future.
Yeah. And one more point on that is we don't know what order the administration is going to put their agenda in, and if repeal Obamacare ends up at even like number 3 or 4, that alone might push it out quite a bit. They've got a big pile of really big campaign promises that were made that need to be addressed. So if a couple of those end up ahead of repeal Obamacare, it's going to be a little while before this conversation really gets underway.
Yeah, I think when you look at both Price as well as Sharma, who the two that were selected, because they're tacticians and not necessarily strategists, I think the strategy will come from Congress. So the idea of, even if they could repeal it tomorrow and just not say, and I think from a public perception point of view, a repeal, I think Niam could be quick, but it doesn't have to be applied for 5 years, right? You could repeal it and say that we're going to stop funding it, or we're going to shorten the funding. Like, for example, the Centers for Medicare and Medicaid Innovation, that could get line item taken out because it just doesn't have funding anymore. So there are ways of repealing that without doing the replacement. But those patients that are sitting, those members that are sitting on the Medicaid because most of the growth in the last 4 or 5 years came on Medicaid. That's where people are worried about, is that if you move to block grants into states, which is most likely, the other question then boils down to, will Medicare become more voucher-based? And if so, what does that allow? I mean, I think, again, this is that scenario where if it's decentralized, innovation happens fast. And now if it becomes more, like even if it's a small portion of it, let's say that for all those Medicaid patients, you could instead move them to a Medicare-ish voucher program, which was what was discussed a few times over the last 10 years is, Medicare and Medicaid could be combinable, except they become voucher-based or they become subsidy-based on some of the low end. So I think you're right, Niam, that the idea that even Republicans that were opposed to Obamacare would somehow be mean enough to drop all these folks on the rolls, that's not likely to happen, not only because it's not politically tenable, but because, Republicans and Democrats are both human beings. I don't know of any Republicans who are like, oh yeah, let's be mean to poor people just because Democrats say that they are, or vice versa. The people in the Democrats environment where they love government doesn't mean that they don't like innovation, right? There's a lot of nuance here. And that's, I think, what's happening is that this polarization has removed that nuance. We're all people. We want to do the right thing. We're in healthcare. We love helping people. That's the whole reason why we're in healthcare. And we sometimes demonize insurance companies, and sometimes insurance companies demonize healthcare providers. But what we need to do is to take this opportunity. We've been jolted a bit, and sometimes that jolt should scare us. And now maybe let's level set and reset and say, where do we get the benefit from centralization? Where does decentralization benefit come from? How can we take these innovations and still help them scale? Lots of work to do. Lots of excitement, I think, for me, at least over the next couple of years. I'm very optimistic about it.
Yeah, I am as well. And I think that this is what makes working in healthcare so interesting is we have this kind of schizophrenic view of the world. And that on one hand, we want it to be a free market and we want there to be innovation. We want everybody to have the freedom to do whatever they want. But on the other hand, as you said, we want to take care of the people. And we don't want people to be left out. So it's not like you can never have a free market in healthcare like you can have a free market in the auto industry, because nobody here is upset that somebody middle class, lower class isn't driving a Rolls Royce and they feel like they should be able to have a Rolls Royce because they're available and they're really nice. They're like, that dynamic doesn't exist. But healthcare, we want everyone to have the best healthcare, and if somebody is being treated for cancer, we don't, as a society, want to sit back and say, well, that person can't afford the best drugs, and that person can't afford the best, and that drives a lot of this debate too. So it's a really complicated matter. But where I kind of draw my position from it on it is that most of the regulation and policy that we're talking about, that again, innovators and doctors say gets in the way, is all about the measuring of how they're doing it, and measuring quality, and saying you have to do things this way versus that way with your technology, and you have to integrate with these people or those people. And I think that's like, I don't believe we will ever solve the problems of healthcare in terms of lowering costs, improving quality, improving access by regulating the way it's delivered. I don't think that that's a possibility. I think that there's benefits certainly from some forms of the centralization, but knowing that our goal is to kind of stop this thing from driving off a cliff over the next 25 years in terms of cost and access, I think that decentralization is probably the only reasonable path towards that. And in the short term, we have to figure out, how can you move from a very centralized, regulated model to one that is less so, without there being, major gaps of care for people that really, really need it in the middle, in the short term. And I think that's where the challenge is going to come from. Any solution, whether it come from this administration, the next one, or 4 or 5 down the road, eventually it's going to have to be dealt with, and that's going to be a challenge.
Yeah, and let me add this, since you mentioned quality measurement and cost reduction. I think the only system in the United States that is very similar to the healthcare system is our education system. And we have very similar problems in the education system likewise. And the underlying common factor in both of these two systems is that the ultimate customers, which are patients and students and their families, really cannot make a choice, either because they don't have the information to make an informed choice, or they have the information, but their choice is restricted. So when it comes to the education system, although there are reliable sources of information about the quality of different schools, my choices are limited, mostly because of the location that I live in. So I have to go to the nearest schools or the schools in my neighborhood. In healthcare, it's even worse because we don't even have reliable information to gauge the quality of the healthcare services that we receive from different providers. Now, the government is trying to make that decision for us through macro, both in the MIPS part and both in the APM model. However, I think the government is repeating the mistake that it made through the Meaningful Use program by thinking that they are the ones who know what is right for everybody. And they're going to fail. I firmly believe that it is impossible for the government to go out and measure the quality of the services that every physician, not only physician, all clinicians, so nurse practitioners, physician's assistants, and all those people are providing to their patients and reward them accordingly. I think the best that the government can do and should do is to make sure that it provides the information that patients, their families, and their physicians need to make an informed choice, and therefore create competition among the providers in the healthcare system. So rather than the government being the primary customer whom the medical providers are trying to please by reporting some arbitrary measures of quality, which costs a lot to them, and again, forgetting all about the patients. So in both the APM and MIPS, I really see no focus on patients. All the focus is how the government is trying to measure the quality of the providers and reward them or penalize them. Patients are completely forgotten. I think that the only solution forward is the only tested and proven solution in every other market. And that is to provide reliable information, be completely transparent to the ultimate customers, and let customers choose the winner rather than the government choose the winner.
Yep. I'm not getting any audio from Shahid. Can you hear him, Niam?
No, I cannot hear it.
Yeah, we're getting no audio from you. So while he listens.
Now?
Oh, there you go.
Okay, good. All right. So what I was saying to Niam, I completely agree. If you look at the model and say, well, what should the government's job here be is level the playing field, and I think that's pretty common. The question is, in this case, given that we're a heavily intermediated health system, intermediated through a variety, I mean, money only comes from two places. It's either the patient or the employer and risk bearer, whoever that might be. And in some cases, that's the government because it is the largest payer in many cases, especially for the elderly. So when you look at these two areas of where the money is coming from, until we can move the money, and this is what I mentioned in my talk yesterday, is employers have to get smarter. And this might be the wake-up call to say, hey, employers, you're putting in 46% of all healthcare dollars are coming from healthcare and employers in general. Something like 40-something% are coming from the insurers like state and government. And then another 15 to 20% is coming from us as spending in healthcare. When you look at where the money is coming from, if that doesn't change, and that was a point that I was making to innovators at MedStarter yesterday, was if you don't change the intermediation model and the money still comes from the same places, it just doesn't matter what the government does. It doesn't matter what anyone does, because all of this is going to follow money. If I can move, however, real consumerization is going to come when more of that money comes. And we saw this happening with the ACA and the higher deductibles and more co-insurance and things like that. But that really hasn't changed consumer buying behavior as much as we wanted to. So if the government does what Niam is saying, which is leveling the playing field, increase the transparency, get itself out of the measurement business, it can do that widely speaking, but how is it going to do that on the Medicare side where it actually has to pay the claims? So unless we're going to move to a voucher system and say, okay, you get a voucher and patients start to pay their own claims, quote unquote, that's where I think, Niam, they might have more responsibility and might have more benefits if we do the transparency and help the government level the playing field. Is that what you meant, or was it something else?
Absolutely. And then another part which is usually ignored, and I think although the money for my care may come through my employer or the government insurance that I have, I also have a skin in this game, and that is my overall well-being in healthcare. So I may not care who pays for it, but I do care about the quality that I receive. So if my employer says that you have the choice between physician A and B, I'm going to pay the claim regardless, then my choice is to select the one that provides better quality. I still don't have that choice. In the very rare examples where that information is being provided, we see surprising shifts in the market share. I give you two examples. One of them is in the context of nursing homes, where since Medicare has started to release information about the quality of the nursing homes through the Nursing Home Compare website, we see a significant change in the market share of the five-star nursing home, saying that they observed an increase in their market share and a decrease in the market share of the one-star nursing homes. While there is no financial reward involved here for patients and their families and their physicians to make a better choice, we see they still make a really good choice by moving from low-quality nursing homes to higher quality nursing homes because they want to receive better health care. Another recent example is from the paper that Chandra at Harvard and his colleagues published on the effects of hospital compare ratings on the market share of the hospitals, and they basically showed a very similar example. So yes, I do agree with you that we have to think about where the money comes from, and I am very pessimistic about this issue that as long as it's not a truly free market, we cannot expect to see, true innovation and true quality improvement as we see in, for example, auto industry, while also agreeing with Don that we cannot expect it to be free market. So I think at the end of the day, we should accept some level of inefficiency and say that we are paying for that inefficiency because we want everybody to have access to good care for humane reasons. But at the same time, I think we should think about solutions to change the flow of the money. Voucher programs is one of them. Even without them, we should think about better ways to inform patients. And I believe that if I, check the ratings of a restaurant before having my lunch there, then I would most definitely check the ratings of a hospital or a surgeon or even a primary care physician before going to their place, even though I don't have to pay for the care that I receive, but the quality is something that I do care about.
Right. No, I think, Niam, you're 100% right. I think it was also, I think Zibdi Helta just mentioned as well that in a non-intermediated system without narrow networks, choice is prevalent and we can make our choices. But really, when you're looking at narrow networks, because of the way that payments are made, because of the way intermediation works, and the fact that we're getting narrower and narrower in networks and choice of HCPs and choice of health systems, et cetera. I mean, just recently, there are a number of healthcare insurers who have further narrowed the networks because they can't afford to create the larger networks in the case of PPOs and things like that. So I'm optimistic. I would love for this idea that money isn't going to drive as much consumer choice, as much as transparency and information. But how does the idea of narrow networks, the fact that health insurers are binding themselves more and more to specific areas of coverage and things like that, which is restricting choice. So it's great if I have ratings and in a world of expanding choices. But what if I have ratings in a world of conflating choices, not growing ones? What do I do in those circumstances? I mean, do you see that as a problem?
Yeah, of course. I think the situation that you're explaining is very similar to the situation that we have about schools. We have ratings, but we have limited choice. So I think it sucks even more to send my kid to a school that I know is bad and I can't do anything about it. So that is exactly what you're explaining that is going to happen when insurances are going to have narrow networks. Despite the fact that you may have ratings at the hospitals and physicians, you don't have any choice, so you have to go to a doctor knowing that it is not the best doctor out there. And but changes in the payment models, the voucher programs and other programs similar to that, or having very large health savings accounts, I think to some extent would help to at least slow down that narrowing of the choices.
Very good. So, I mean, these are the types of problems that that we can't predict how they're going to play out, and that we certainly know are going to take a really long time. And that's what I really liked about your slides, Shahid, from this week. And I'm excited that that's online. I will share a link with everybody. That's why I want to jump into your talk a little bit about now from an innovator standpoint and from a just a healthcare organization's operational planning here going forward. We're looking at all this uncertainty. We don't know where it's going to go. What are the things that you believe we should be focusing on right now on that front so that we don't get caught up in this hype cycle and, kind of spin our wheels out on issues that we just can't predict? What should we be doing today?
Yeah, I don't think anyone should really, regardless of what industry you're in, don't do anything different right now. You got to wait at least at a minimum. Number one, laws, the statutory side, are not going to change fast. So if statutes don't change, it means regulations cannot change because those statutes drive regulations. The only thing that could change is the administration could come in and start with executive orders. Executive orders do have force of law in many cases, and as far as the outcomes are concerned, but they can't be as broad. Like, they can't create new spending. They can't stop spending things that Congress said you must spend on. So there's a lot going on here that really doesn't deserve attention until Congress starts to move. And then what Congress creates establishes a framework, for statutory framework for regulatory action. That regulatory action then establishes the strategic goals and the strategic imperatives that CMS, whether it's Medicaid, Medicare, all the other agencies, are all going to have to react to statutory changes. They don't just react because people in the news say something. It doesn't matter what we say on Facebook or Twitter, what a fake news article might say or a real news article might say. None of this matters. What matters is if you don't see a law being covered on thomas.gov, if you don't see the Federal Register coming out with specific things that you have to worry about, if you don't see the strategy changing, if you can't, for example, there's multiple systems where the budget of the agencies for the United States government are well documented. If you don't see line items in budgets, if you don't see appropriations language being changed, don't do anything, right? That's where you're speculating. You're like, oh, this might happen and that might happen. Nothing in the government can happen without it being written down, without it having gone through process, etc. Now, people within government can break laws and not do things that Congress said, or etc. And then there are ways of getting around certain kinds of things like that. But I would say nobody should be adjusting their goals going forward, because healthcare is not going to be any different 5 years from now than it was 5 years ago. From a disruption point of view. From an innovation point of view, start to worry about where you think your needs might be from a centralization versus a decentralization innovation model. That's really the only thing that's going to change over the next 4 or 5 years, is where do these decisions get made? Because the spending on entitlements are the spending on entitlements. It doesn't matter what anyone does. If the entitlement rules don't change, that spending doesn't change. And nothing there is being adjusted anytime soon. So I'd say don't change there. The employers are starting to listen a little bit more to, are starting to dictate more to insurance companies instead of the other way around. So if you're in any angle which can sell to employers, explain to employers how they can empower themselves, get employees to be more accountable for the help that they are taking control over to their employers, that I think is something that can change with no government regulations. I mean, that can absolutely change on a dime. An employer can choose to do one thing versus another if you could convince them of something. But other than that, I would say from a government point of view, you should sit tight and not do anything for a little while.
Yeah, I completely agree with Shahid. You know, he just put it very beautifully.
Good. And you know, from your post that you wrote about a week ago, Niam, on this topic too, you know, one of the things that I noticed about it was a similar kind of tact is that, yeah, we know that they've said they want to repeal Obamacare. We know they're talking about maybe doing something with insurance across state lines, but we don't really have anything much more specific than that. So let's focus on these issues that we've already been trying to deal with for all this time. And you went into interoperability and security from your standpoint. And I think that's kind of an important issue, or an important thing to bring up too, is that in healthcare, oftentimes we're always looking to solve the next problem and to identify what that next problem is going to be so that we can go and solve it. But we haven't solved all of the problems that we've already been talking about all of this time anyways. So Niam, on that front, you know, from an interoperability standpoint, I thought your comments around data blocking were pretty on point, and I thought that might be a good place for us to kind of pull this together at the end. So, you know, tell us about what you found there and what you're thinking is the issue and the solution.
Yeah, I think one of the things that government is really good at is pointing fingers. And despite billions of dollars that we spent on digitizing the healthcare in the United States, the ultimate goal was to have a smooth exchange of information. The Meaningful Use Program, or the HITECH Act, was not designed so that every physician is now going to have a computer in his office. The intention of those policies was to exchange information and analyze that information so that quality would increase and cost would decrease. Nothing else. And almost 10 years after that date, and spending billions of dollars, which if we don't even have a clear number, some people say 22 billion, some people say 30 billion, it's more than $20 billion. We haven't achieved any of those goals. And now the newest reason that we're being told for that failure is all of a sudden some EHR vendors data blocking and disabling access to their databases, or things like that. And I have a couple of points about that. First of all, I'm not sure if that is a real thing. People have been asked to give clear examples of that. The examples are very anecdotal. So even if that is happening, I'm not sure that is the main reason for the lack of interoperability and information exchange. It may be one of the reasons, but is not the only reason, and most certainly it is not the most important reason. So focusing on data blocking as the only and the main reason for the lack of interoperability, I think, is completely wrong. Interoperability has not been achieved because there is no reason to have interoperability in the healthcare market today. And I think to some part, government is to be blamed for that because of the policies that they designed with the best of intentions led to have really bad results. One of them, I think, the most controversial one is the anti-kickback laws put in the healthcare system to basically protect patients and ensure that the patients receive the best care regardless of the financial incentives of the medical providers. But when it comes to the health IT, what it does in essence is basically it devalues data. So it tells me as a physician that the information that I have collected about the patient cannot be sold and cannot be bought. And when that happens, it's just like, you know, the government telling me that I cannot sell or buy this piece of paper, and everybody has to give it to me for free, and I have to give it to other people for free. Well, guess what? If I cannot make anything out of giving this paper to you, then I don't care how much you want it, you know. I'll come up with all the excuses out there to say that, hey, you know, I really want to comply with this government regulation that tells me that I have to give this papers for free to you, but you know, this door doesn't open as easily as I want it to open, and therefore I'm being locked in this room and I cannot give you this data. So I know it's very controversial, but I think we should create a safe harbor for medical providers to trade data, and trading any kind of commodity is the only way that is going to exchange. And I think data is no exception. So let people and let the free market put a value on the medical data, and as soon as you put a value on that, trade, which means exchange, will automatically happen. That is the first thing. And then the other thing, which comes back to data blocking and blaming EHR vendors for that, it's very interesting. All of those EHRs are the ones that comply with the certification requirements of ONC. So I wonder if the data blocking activity that they are engaging in is an illegal action, something that was not written into the law, or they have found a loophole around it. I bet it's the second option, because if it was illegal, there are so many lawyers and attorneys there in the healthcare who are waiting for somebody to go and sue. And I'm pretty sure that Epic and Athena and, you know, all those other EHR vendors have been sued now. The reason that we see no legal action against those EHR vendors is primarily because the fact that they are following the law. And the problem is the law, not those people. I do not disagree with the fact that it is in their best financial interest at the moment to block the data. However, they are doing it legally. It's like Trump not paying taxes. You know, every other person in that situation would have avoided paying taxes following the loopholes in the law. So I think rather than blaming the people who take advantages of the loopholes in the tax laws, we should go back and fix the tax laws. And the same thing goes for data blocking. I think we should be very honest with ourselves and say, are they doing anything illegal? And if they do, we should bring legal action against them. If they're not doing anything illegal, then, you know, who is to blame? Is the EHR vendors, or is it the people who made those rules and laws? So
yeah, I don't think there's any to believe. Yeah, I think you're 100% right, and we're about a minute away from closing up. I think this is a great point to make, is that the EHR companies are not doing things that they were not incented to do. So unfortunately, and this is why laws and the way that we make them is so important, because what we said was we're going to create a demand side for electronic health records. We're going to pay for that demand using government dollars, and we're going to ensure that that demand fulfills our requirements by making sure that people had features and functions in their systems. That was the biggest mistake, right? The law should have instead said that I will create a massive data validation exchange environment where I'm going to validate that data can be exchanged properly. And if you can exchange this data with at least one other group or 50 other groups or whatever, then and only then will you get the incentive money. But that's not what we paid the incentive money for. We said, buy the software with these capabilities, install it, use it, and then I will pay you. Well, that's exactly what happened. Guess what? You pay people to do what you want them to do, and then they do it. That's all that's happened in this case. So we need to step back and say there is no actual data blocking per se going on with respect to a national, very well orchestrated blocking effort from any vendor. They're not that smart. They can't actually pull that off. It's really a demand side problem. The real reason we have data blocking is because people do not get together and say, I will stop buying from vendors who are doing this action. In any other area, when we stop buying from people who are doing those actions, those vendors change their actions. And in our case, we have a demand side problem, not a supply side problem. And until we get that understanding, it's like employers saying, well, why aren't insurers doing things that we want them to do? Because you keep paying them even though they don't do the things you want them to do. So why are you surprised that you keep paying vendors to do the things you don't want them to do and they keep doing them? Well, stop paying them. Use someone else. Move from closed source to open source. There are all kinds of ways of getting around this, but we want the easy route, which is, big brother government should take care of all this for me. Data blocking will somehow go away. I think, Niam, you're 100% right. Yep. There's nothing illegal going on here. It's following what the incentives were created, and that's where that's what we're sitting at. So Don, I'll let you take it away.
Yep,
with
absolutely.
Myself here, we could go for hours.
Yeah, and indeed, it's been great. It's great to be back on Fire Talk. I love the conversation going off to the side here. Can't wait to get through that and read it. So thank you everyone for joining us. But my parting comment will be a famous quote, which I knew who it was from, but basically every system is designed perfectly to work exactly how it works. And that's what we're dealing with here. So great having you guys. I really appreciate it. And we'll talk again soon.
Thank you very much. Goodbye.
Have an awesome day.
You too.